You wake up, and before your eyes are even fully open, it starts. The itch behind the eyes, the heaviness, the sneeze that comes in threes and then in fives, and then you lose count entirely. You have carried antihistamines everywhere for years. Allergic rhinitis is not a nose problem. It is a signal, and that signal has measurable answers. You wake up, and before your eyes are even fully open, before the first thought of the day, before the first light has reached the room, it starts. The itch behind the eyes, the heaviness pressing into the sinuses, the sneeze that comes in threes and then in fives, and then you lose count entirely. The nose that runs and will not stop. The throat that catches. The fog that settles over your mind before the morning has even begun. And somewhere in that fog, a thought. Not again. Not today. You have had that thought for years, perhaps since childhood. Perhaps since that first monsoon when the mold spores came and something in your immune system shifted and never quite shifted back. Perhaps after a viral fever that seemed to rewrite something fundamental in your body. Perhaps you cannot even identify the beginning. It is simply how you are now, how you have learned to be. You carry antihistamines everywhere, in your bag, in your office drawer, on your bedside table, in your car. You know which environments will trigger you and you avoid them when you can. You have explained your allergy to every new colleague, every host, every hotel room attendant asking if you want the windows open. You have built your life around a condition that was never supposed to be permanent. And the question you stopped asking years ago, because nobody has given you a satisfying answer, is this: why? Why does your immune system behave this way when your colleagues does not? Why has a decade of antihistamines not changed the fundamental picture? Why does the season feel longer every year? Why are you developing new sensitivities you did not have before? These are not rhetorical questions. They have answers. Specific, biological, measurable answers. And today, we are going to give them to you. If you have lived with allergic rhinitis for any serious length of time, you have not just taken antihistamines. You have tried other things, many things. And we want to acknowledge that with complete respect, because the effort people put into trying to heal themselves deserves an honest clinical response, not dismissal. Perhaps you started with the home remedies. Turmeric was probably first. Golden milk every night, the way your grandmother suggested and the way wellness content online reconfirmed. And turmeric contains curcumin. Curcumin does have real anti-inflammatory properties in laboratory research. We are not disputing that. But curcumin has extremely poor oral bioavailability. Without specific pharmaceutical formulation, the amount reaching your immune cells from a daily teaspoon in warm milk is not enough to produce meaningful therapeutic change. You may have felt a small reduction in heaviness on some mornings. That was not the curcumin working on your Th2 immune arm. That was the warmth of the liquid soothing inflamed mucosa temporarily. The problem was never the effort. The problem was that the tool was not matched to the depth of the problem. Perhaps you tried tulsi, holy basil tea every morning, adaptogenic and ancient, genuinely protective in some contexts. Perhaps steam inhalation with eucalyptus oil, which does provide temporary decongestion by thinning mucus mechanically. Perhaps saline nasal rinses, the Jal Neti practice, which we will say plainly does offer real value as supportive care. Daily nasal irrigation reduces the allergen load sitting on the nasal mucosa before immune activation occurs. That is worth doing. But it is cleaning the surface of the problem. It is not speaking to the immune system that created the problem.
And perhaps you went deeper. Perhaps you explored Ayurveda seriously. A practitioner assessed your Prakriti, identified Vata-Kapha imbalance, elevated Ama. You were prescribed Haridrakhand or Sitopladi or Trikatu. You followed a specific diet, no curd after sunset, warm meals, specific spices, seasonal adjustments. You took the churna faithfully for months, and perhaps things did improve to some degree. Perhaps the heaviness lifted. Perhaps the frequency of sneezing reduced. We want to say this with genuine respect. Ayurveda's understanding of the relationship between digestive health, immune function, and constitutional reactivity is profound. The concept of ama as metabolic residue has real equivalents in modern gastroenterology. Gut permeability, endotoxemia, the cascade of inflammatory signals that emerge when the gut barrier fails. The Ayurvedic practitioner was intuiting something real. The intuition was not wrong. But here is the clinical gap. Without measuring vitamin D3 before and after, without tracking eosinophil counts over time, without watching total IgE as a proxy for the allergic immune load, without PTH levels confirming that D3 is actually being absorbed and utilized, how do you know the immune environment is genuinely shifting? How do you separate real immune rebalancing from a temporary improvement in mucosal comfort? And when symptoms return in the next monsoon season, what is the next step? Another churna? Another constitution reassessment? Another weight? The philosophy is sound. The execution lacks the biochemical backbone that would make outcomes reproducible, measurable, and explainable. That is not Ayurveda's failure as a system. It is what happens when any therapeutic tradition is practiced without integration with modern diagnostics. And perhaps you tried homeopathy. Perhaps you sat with a careful practitioner for 2 hours while they explored your constitutional picture, your fears, your sensitivities, your physical tendencies, your emotional patterns. And they selected a remedy with precision and care. And for a period, things were better. The sneezing reduced. You had more energy. The mornings felt lighter. We will not dismiss that experience, because dismissal is not science. In some patients, constitutional homeopathic care appears to support immune regulation through pathways that are not yet clearly understood. The therapeutic relationship itself has measurable physiological effects on stress hormones. Improved sleep, reduced anxiety, dietary changes made alongside homeopathic treatment. All of these can reduce the inflammatory burden on the immune system. We acknowledge all of that. But what the peer-reviewed evidence does not consistently demonstrate is measurable, reproducible change in the core immune parameters driving allergic rhinitis: Th2 cytokine levels, total IgE, eosinophil counts, D3 status, and gut microbiome architecture. Which means that even when homeopathy helps, neither the patient nor the practitioner knows with certainty whether the immune terrain has actually been restored. And when improvement stops, there is no blood work to guide what comes next, no roadmap forward. You have been trying for years, and you deserve more than hope. You deserve mechanism. You deserve measurement. You deserve an answer that explains itself through biochemistry, through monitoring, through reproducible outcomes in thousands of patients across years of practice. That is what we are building toward today. Every year that passes with allergic rhinitis managed only at the symptomatic level is a year in which the underlying immune dysfunction is not just persisting, it is progressing. This is not fear-mongering. This is the documented natural history of untreated Th2 immune dominance. Allergic rhinitis does not simply remain a nose problem indefinitely. There is a well-established phenomenon called the atopic march, the predictable sequential progression of Th2 dominant immune disease through the life course. Atopic dermatitis first, then allergic rhinitis, then asthma in a substantial proportion of patients. Not because asthma is a separate disease that arrived by coincidence, but because the same immune environment, the same chronically elevated Th2 cytokines, the same perpetually primed mast cell populations simply found a new tissue address. The antihistamine you take every morning is not stopping this progression. It is managing the output of a process that continues completely upstream. And every year the process continues. The immune dysregulation deepens its roots, involves more systems, and becomes harder to fully reverse. This is the clinical reality, and it is the reason that understanding root cause, not just symptom management, is not a philosophical preference, it is a medical necessity. Your immune system has two primary operational modes:
Think of it as a security team divided into two divisions. The first division is precise, methodical, trained to identify specific threats at the cellular level: viruses, intracellular bacteria, abnormal cells. They operate with surgical efficiency. They do not overreact. This is your Th1 arm, your cellular immunity. The second division is built for a completely different category of threat: large parasites. Organisms too large to be engulfed by individual immune cells. Things that require a chemical mobilization, a flood of inflammatory signals, a coordinated mass response. Mast cells, eosinophils, IgE antibodies. This is your Th2 arm, your humoral immunity. In a healthy immune system, a regulatory layer, the T regulatory cells, acts as command authority over both divisions. It ensures proportionality. The right team activates for the right threat. When the threat is resolved, the team stands down. Balance is maintained. In allergic rhinitis, this command authority has collapsed. The Th2 division has gone rogue. It is chronically dominant. It is permanently mobilized. And it has made a catastrophic misidentification. It has classified a dust mite, a pollen grain, a pet dander particle as a large parasitic threat requiring full mobilization. Every time you inhale one of these harmless particles, your body deploys its full anti-parasite arsenal. Mast cells detonate. Histamine floods local tissue. Eosinophils pour into the nasal lining. IgE antibodies are produced in quantities that serve no functional purpose. And you sneeze, and your nose runs, and your eyes itch, and the fog descends. The cetirizine you take every morning blocks the histamine receptor. It does not stop histamine from being released. The mast cell still detonates. The Th2 arm is still dominant. The IgE is still being produced. The antihistamine intercepts one signal at the very end of a cascade, while the cascade continues completely unaddressed upstream. This is why you take it every morning. Not because the condition is being controlled, because one of its final outputs is being chemically silenced. There is a meaningful difference between those two things. And understanding that difference is the beginning of finding a real path forward. The question that transforms everything is not what your allergy is. It is why your immune system became Th2 dominant in the first place. Because once you understand the why, the therapeutic direction becomes clear. The guesswork ends, the measurement begins, and the path toward genuine rebalancing opens. In clinical practice, evaluating patients with chronic allergic rhinitis, we consistently find three converging root drivers. They do not operate in isolation. They amplify each other, and each one, under proper clinical supervision, is addressable. The first driver is your gut. 70% of your immune system lives in your gut. Not in your sinuses, not in your bloodstream. Your gut. The gut-associated lymphoid tissue, the GALT, is the primary educational institution for your immune cells. It is where T regulatory cells are trained, where immune proportionality is established, where the system learns what to attack and critically what to leave alone. In a healthy, diverse, appropriately colonized gut, this education is rigorous and complete. Your immune system learns tolerance. It encounters environmental particles and does not declare war. This is called oral immune tolerance, and it is built almost entirely in the gut. When gut dysbiosis occurs, this entire educational architecture collapses. Microbial diversity falls. The regulatory T-cell training that maintained Th2 balance breaks down. The Th2 arm loses its correction signal, and without correction, it dominates. Research confirms that gut microbiota dysbiosis is a primary upstream driver of allergic rhinitis. Not an incidental finding, not a coincidence, a primary driver. The same research demonstrated that probiotic intake was a protective factor against allergic rhinitis, with a 72% relative risk reduction observed in specific populations. 72%. That is not a minor association. That is a signal about root cause. And here is the India-specific dimension that most allergists in standard practice miss entirely. Research conducted in urban and rural populations close to the equator found that vitamin D deficiency prevalence was 47% in the urban population compared to only 7% in the rural population. And asthma and atopy prevalence followed that exact same gradient. 12% in the urban group, 3% in the rural group. India's rapidly urbanizing population,
spending less time outdoors, living in polluted cities, eating processed diets, sits squarely in this high deficiency, high atopy risk category. This is not coincidence. This is biology following geography. A significant proportion of patients with chronic allergic rhinitis in India, particularly those with elevated eosinophils on their blood count, also carry a background parasitic infection burden. Subclinical, no dramatic symptoms, just quiet, persistent, low-grade immune priming that keeps the Th2 arm continuously activated. Every allergen encounter lands on an immune system that is already in a state of mobilization. The reactivity is amplified well beyond what the allergen alone would produce. The complete blood count with differential tells you this story directly. Elevated absolute eosinophils, active allergic or parasitic immune hyperactivation. Elevated neutrophils, background viral burden. Elevated lymphocytes, possible fungal colonization. Each number is a flag. Each flag has an addressable driver. And standard allergy evaluations almost never read the differential this way. The second driver is vitamin D3. Not the bone mineral you were taught about in school, not the supplement your physician suggested at 600 units once a day during winter. Vitamin D3 is a steroid hormone. It regulates more than 2,700 genes. And among its most critical immunological functions is the direct modulation of T-cell balance, suppressing Th2 cytokine production, promoting T-regulatory cell expansion, and reducing IgE synthesis at the source. When D3 is deficient, the immune system loses one of its primary molecular brakes on Th2 dominance. The allergic arm runs without adequate correction. IgE climbs, mast cells remain primed and reactive, eosinophils stay elevated, and every morning continues to begin the same way it has for years. Research found that vitamin D deficiency was associated with a nearly two-fold increase in sensitization to dust mites, one of the most common allergens in allergic rhinitis globally. Separate research found significantly lower vitamin D3 levels in patients with allergic fungal rhinosinusitis and nasal polyp disease. And a review of VDR gene polymorphisms confirmed that individual genetic variation in vitamin D receptor function influences atopic disease susceptibility independent of circulating B3 levels. This last finding matters enormously in clinical practice because it means that some patients have a D3 level that looks adequate on standard reporting but is not producing adequate cellular immunomodulation. The receptor is less responsive. The conversion from circulating D3 to active calcitriol is less efficient. The cell does not hear the signal, even when the signal is present. This is vitamin D resistance. And it is something that standard laboratory reporting never flags because it only measures what is circulating in the blood, not what the cell is actually receiving. PTH, the parathyroid hormone, is the clinical indicator we use to detect this resistance. When PTH remains elevated, despite a D3 level that appears borderline adequate, the body is communicating that it is not satisfied. It is calling for more D3 signaling than it is currently receiving. This is a red flag missed in virtually every standard allergy workup. The third driver is chronic infection burden, and it is the one nobody discusses. Parasites are not simply gastrointestinal nuisances. They are ancient, highly evolved immune manipulators. Over millions of years of co-evolution with human hosts, they have specifically learned to hijack the Th2 arm of the immune system, because Th2 is the arm designed to fight them. By keeping Th2 chronically activated, they suppress the Th1 response that would clear them. And in doing so, they simultaneously keep your allergic immune arm in a state of continuous mobilization. A subclinical parasitic infection, even one producing no dramatic symptoms, creates a persistent baseline of Th2 readiness. Every allergen encounter is amplified against this background. You are not simply reacting to a dust mite. You are reacting to a dust mite on top of an immune system that a parasite has already placed on high alert. Add to this the fungal colonization that is substantially more prevalent in India than is clinically recognized, particularly in patients who have undergone repeated antibiotic courses, and you have an immune ecosystem under multiple simultaneous pressures. Viral burden suppressing Th1, parasitic burden priming Th2, fungal burden adding lymphocytic stress. And beneath all of this, a gut architecture disrupted by every antibiotic course taken over the preceding years, unable to produce the regulatory T cells that would hold the entire system in balance. This is the actual picture, and an antihistamine addresses none of it. Here is something we want you to sit with for a moment. The majority of patients who come to us with chronic allergic rhinitis have a vitamin D3 level below 25 nanograms per milliliter. Many are below 15, some are below 10. These are not levels associated with mild deficiency. These are levels associated with significant immune dysregulation. At these levels, the molecular brake on Th2 dominance is essentially absent. The immune system is operating without one of its most fundamental regulatory signals. And it has been operating this way, in many cases, for years, even decades. Meanwhile, the standard clinical response to this picture has been to prescribe cetirizine, to manage the expression, to ignore the driver. Your total IgE level matters here too, because a significantly elevated total IgE is not just confirming that you have allergies, it is a quantifiable measure of how far along the Th2 dominance spectrum you currently are. And in the context of the atopic march, a rising total IgE is an early warning that the immune dysfunction is not staying local to the nose. It is systemic. It is looking for its next tissue address. If you have not had your vitamin D3 checked alongside PTH or your total IgE measured recently, you are missing the two most important data points about where your immune system actually stands. And those missing numbers may be the single most important reason your allergic rhinitis has not resolved. Most people with chronic allergic rhinitis have had blood taken many times. Most of them have never had their blood properly read. There is a significant difference between running a test and interpreting the result through a systems lens. Vitamin D3 and PTH together form the opening statement of the immune story. D3 alone tells you the circulating level. PTH tells you whether the body is satisfied with that level. When PTH is elevated alongside a D3 that appears borderline adequate, it is the body signaling that cellular D3 activity is insufficient. Something between the supplement and the cell is not working. Most commonly, that something is in the gut. The fat-soluble hormones, and D3 is a fat-soluble hormone, require healthy bile production and adequate digestive enzyme activity for proper absorption. In patients with gut dysbiosis, chronic gut inflammation, or impaired biliary function, fat-soluble nutrient absorption is significantly compromised. Supporting bile salt production and restoring digestive enzyme function dramatically improves absorption in these patients. Not as an optional step, as a mechanistic prerequisite without which D3 supplementation at any dose will produce disappointing results. Total IgE gives you the aggregate Th2 load, the total volume of the allergic immune signal circulating in your bloodstream. A markedly elevated total IgE is not simply confirming your diagnosis. It is telling you that your Th2 arm is substantially and chronically overactivated. The absolute eosinophil count, read within the context of the full differential, is the fingerprint of what is driving that overactivation. Persistently elevated eosinophils in a patient with allergic rhinitis who also reports subtle gastrointestinal discomfort, rectal itching, or a history of skin reactions to certain foods should prompt a clinical conversation about background parasitic burden. This is a conversation that almost never happens in standard allergy care. Fasting insulin tells you about the metabolic terrain. Insulin resistance creates a pro-inflammatory cytokine environment through TNF-alpha and interleukin-6 elevation. This environment directly compounds Th2 dominance. A patient with chronic allergic rhinitis and slowly rising fasting insulin is not dealing with two separate problems. They are dealing with one broken metabolic immune terrain expressing itself in multiple directions simultaneously. Free T3, the thyroid parameter that is almost universally ignored in standard workups, tells you about thyroid hormone's direct role in immune cell metabolism. Subclinical hypothyroidism, which can exist when TSH is technically normal but free T3 is suppressed, impairs immune cell metabolism directly. It is completely invisible if your clinician only checks TSH. Taken together, this blood work does not just confirm your diagnosis. It maps the immune ecosystem. It identifies what broke and in what sequence. It creates the foundation on which rational, targeted, measurable therapeutic intervention becomes possible. Before we continue, we want to address the practical question we know many of you are already asking. Where do I get these tests done? And what is it going to cost? We work with Redcliffe Labs across India as our partner laboratory for all patient investigations. This is not an advertisement. You can get these tests done at any reputable laboratory. But we want to be transparent about why we specifically recommend Redcliffe to our patients. The cost through Redcliffe is substantially lower than most major laboratory chains, almost 70% lower in many cases. They reach most PIN codes across India, including areas where access to quality diagnostic infrastructure is otherwise limited. Over years of building clinical protocols for autoimmune and inflammatory disease management, their consistency of reporting and quality of sample handling have supported our clinical decision-making reliably. The complete panel you need before any integrative clinical evaluation for allergic rhinitis includes the following: vitamin D3, intact PTH, CBC with differential, total IgE, fasting insulin, HbA1c, thyroid profile with free T3, vitamin B12, homocysteine, iron studies with ferritin, lipid profile, liver function tests, kidney function tests, serum calcium, ionized calcium, and urine routine. A fuller panel may be needed depending on your individual clinical picture. The link to organize this panel is in the description below, or reach out directly to our reception and they will help you organize this correctly. Do not begin any supplementation protocol without this baseline. The blood work is not the optional first step. It is the only first step. Everything else follows from what it shows. We need to be precise here because precision is what separates clinical medicine from wellness advice. Everything that follows requires supervised clinical management, individual assessment, individual blood work, individual titration, individual monitoring at defined intervals. What follows is a framework for understanding the therapeutic logic, not instructions for self-treatment. Please hear that clearly, because well-intentioned self-treatment in this clinical domain causes real harm. The therapeutic approach that addresses root cause in chronic allergic rhinitis works through 4 converging interventions. They must be implemented together. They must follow appropriate sequencing where sequencing matters. And they must be adjusted based on what the blood work shows at each monitoring interval. The first is gut rehabilitation, not a random probiotic from a pharmacy shelf. Systematic, sequenced, supervised gut restoration. This begins with identifying and addressing the infection burden, parasitic, fungal, and bacterial, in the sequence appropriate to what the investigation reveals. This is followed immediately and concurrently by active microbiome rebuilding through spore-based multi-stream probiotics, capable of surviving the gastric environment and genuinely colonizing the gut lining, combined with prebiotic dietary support. And running beneath all of this, specific attention to gut barrier integrity. A compromised gut barrier is a continuous source of allergen and microbial product entry into systemic circulation, providing constant Th2 stimulation that no antihistamine can address. The second is vitamin D3 repletion at a level that is clinically meaningful for immune function. And here we need to be honest about something that standard practice consistently misunderstands. The vitamin D3 level sufficient to prevent rickets is not the same level required to meaningfully modulate Th2 cytokine production and support T regulatory cell expansion. Experienced integrative clinicians working in immune modulation work toward levels substantially higher than standard laboratory normal ranges suggest. The specific target is determined by individual blood work, clinical response, and monitoring parameters, particularly ionized calcium and PTH that confirm safety at each interval.
Before D3 can work effectively at any dose, the absorption pathway must be functioning. In patients with gut dysbiosis and impaired biliary function, therapeutic bile salt support is required to restore fat-soluble vitamin absorption. Digestive enzyme support restores the gastric and intestinal processing capacity needed for proper fat-soluble nutrient utilization. These are not optional additions. They are the mechanistic foundation that determines whether D3 ever reaches the cells it is intended to reach. Magnesium is non-negotiable within this framework. It is required at every enzymatic step of the D3 conversion pathway. Without adequate magnesium, D3 supplementation at any dose produces significantly impaired cellular effects. Vitamin K2 ensures that calcium mobilized by rising D3 is directed towards bone, not soft tissue. The third is targeted immune modulation through specific evidence-supported nutrients. Quercetin at therapeutic doses stabilizes mast cells at the cellular level, reducing histamine release before it occurs, rather than blocking the receptor after histamine has already been released. This operates at a completely different level of the allergic cascade than an antihistamine. It is mechanism, not symptom interception. Omega-3 fatty acids shift prostaglandin and leukotriene synthesis away from the pro-inflammatory pathways that sustain Th2 dominance, actively pushing immune balance toward greater Th1 and T regulatory cell activity. Vitamin C supports histamine degradation as a cofactor for the enzyme diamine oxidase, which clears histamine from tissues. These agents are selected because their mechanisms align precisely with the specific pathology being addressed. The fourth is metabolic and thyroid optimization. If insulin resistance is driving a pro-inflammatory cytokine environment, that metabolic dysfunction must be addressed directly. If subclinical hypothyroidism is impairing immune cell metabolism, thyroid support becomes part of the clinical picture. The immune system does not operate in a metabolic vacuum. The terrain in which it operates determines whether the other therapeutic interventions produce durable outcomes or temporary improvements that fade. All four interventions work together. They reinforce each other. When implemented together, monitored through blood work at regular intervals, and adjusted based on what the monitoring shows, the trajectory changes. Not dramatically in the first week, not with a single supplement, but over 6 to 12 months of consistent, supervised clinical work, the blood work begins to tell a different story. Eosinophil counts normalize. Total IgE begins a downward trajectory. PTH adjusts, confirming that D3 is now being received by the body's cellular machinery. And the morning, slowly but measurably, changes. Here is what we consistently observe in patients who have been managing their rhinitis conventionally for 5 years or more. They come to us for the nose, and when we take a full history, the nose was never alone. There is the eczema that flared through university and then quieted, but never fully resolved. There are the food sensitivities that emerged in the last few years. Gluten, dairy, certain fruits, things that never bothered them before. There is the chronic fatigue that general physician attributed to stress. There is the mild but persistent morning stiffness not yet formally assessed. There is the reflux that started in their late 20s, now managed with an antacid every second day. Each of these, in isolation, is manageable with a separate medication. Antacid for the reflux, elimination diet for the food sensitivities, moisturizer for the eczema, cetirizine for the nose. But together, they are telling one single story. The same immune environment that drives allergic rhinitis drives atopic dermatitis. The same gut dysbiosis that removes the regulatory brake on Th2 responses creates intestinal permeability that drives food reactivity. The same vitamin D3 deficiency that allows Th2 to dominate without correction also impairs the thyroid function and mitochondrial efficiency that underlie chronic fatigue. The reflux is not a coincidence. It is the same dysbiotic gut environment expressing itself through the upper gastrointestinal tract. These are not separate problems requiring separate management. They are one broken terrain expressing itself in multiple tissues simultaneously. And every year of managing each symptom in isolation is a year in which the terrain continues to deteriorate
and the list of conditions quietly grows. If what you have just heard describes your experience, not just the nose, but the accumulated picture of years of symptoms managed but never truly resolved, then what you are facing is not a management problem. It is an investigation problem. You have not yet had a complete immune ecosystem evaluation. And until you do, you are not treating the right thing. Our clinical team includes rheumatologists, pharmacologists, diabetologists, nutritionists, and integrative medicine specialists. We assess the complete picture: the immune dysregulation, the metabolic terrain, the gut architecture, the micronutrient status. Not the symptom in isolation, the system behind it. We consult patients across India and internationally. This is a supervised, monitored clinical program. It is not a supplement recommendation service. It is not a common thread consultation. It is a complete, personalized clinical evaluation grounded in your specific blood work. The consultation link is in the description. The first step is always the blood work. The second step is the conversation that explains what the blood work means. The third step is a protocol designed specifically for your immune ecosystem. We look forward to that conversation. Here is something that is rarely discussed in allergy care, but has genuine clinical significance. Immune tolerance capacity, the ability of the immune system to genuinely relearn balance, is higher in earlier stages of immune dysfunction than in later ones. Our tolerogenic capacity is higher in early life and in earlier disease stages, and it gradually decreases as the immune phenotype becomes more entrenched over time. Early interventions targeting immune-shaping exposures and micronutrient status have the potential to shape long ways that later interventions cannot fully replicate. What this means practically is not theoretical. It means that the patient presenting with allergic rhinitis alone has a more recoverable immune landscape than the patient who has progressed to rhinitis plus early asthma plus eczema plus food reactivity. Not because the second patient cannot be helped, they can, but the clinical work is more complex, the timeline is longer, and the outcomes, while still meaningful, require more from both the patient and the clinical team. If you have been managing allergic rhinitis for 5 years, your window for comprehensive immune restoration is meaningfully better than it will be in another 5 years. If the atopic march has already begun, if early bronchospasm or eczema is present alongside the rhinitis, the immune system is telling you that the progression is already underway. The time to investigate root cause is not when the situation becomes critical. It is right now, while the system retains meaningful immune plasticity and while the drivers are still primarily at the gut and micronutrient level rather than at the structural airway remodeling level. The blood work tells you exactly where you are on that spectrum, and the earlier that conversation starts, the better the outcomes it can produce. If you are a clinician watching this video, a general practitioner, pediatrician, ENT specialist, allergist, or integrative medicine practitioner, and you find yourself thinking that you want to understand the clinical protocols, the monitoring frameworks, and the evidence base behind this approach in greater depth, we have a resource pathway specifically for healthcare professionals. We engage seriously with clinicians who want to build genuine integrative capacity in their practice and who are committed to monitoring-based outcomes for their patients. Scientific material, protocol frameworks, titration methodology, systematic training resources, all available. The link for professional enquiry is in the description. We look forward to that conversation. Let us bring this to where it needs to end. Allergic rhinitis is not a nose problem. It is a signal. Your immune system, through every difficult morning and every antihistamine and every home remedy and every brief improvement that did not last, has been communicating the same thing for years, that its balance has been disrupted, that the gut architecture which should have educated it was compromised, possibly in childhood, possibly by antibiotics or infections or diet, or all three simultaneously. That the vitamin D3 it needs to modulate itself is absent, and the absorption system that should deliver it to the cells is not working properly. That a background infection burden it cannot fully clear is keeping it in a state of continuous alert that amplifies every allergen encounter. Every remedy you tried was an attempt to answer that signal with something less than the full answer. Some of them help partially. None of them change the fundamental picture, because the fundamental picture is biochemical, and biochemistry must be measured before it can be changed. In monitored clinical practice, patients who follow compliant integrative protocols consistently show measurable improvement across key immune parameters over a 6 to 12 month period. The blood work is the evidence. The trajectory of the blood work over time is the proof. And the patient who wakes up to a different morning after a year of proper clinical work is the outcome we work toward. We also want to be honest about something before we close. We receive many comments on our videos. We appreciate every one of them. But we are not able to respond to comments with specific clinical recommendations. We are not able to suggest specific products or dosages through a comment thread. We are not able to assess your situation without your blood work and a proper clinical consultation. This is not a content channel at arm's length from clinical practice. It is a clinical practice that uses content to reach patients who might otherwise never find their way to root cause medicine. Everything we do is supervised, monitored, and grounded in individual biochemistry. If you are ready for that level of care, the link is in the description below. Like, follow, and subscribe for clinician-grade scientific content. And if today has given you the clarity you have been looking for, the clarity that your condition has a root and that root can be measured and addressed, do not wait for the next season. Do not wait for another year of the same morning. Begin with the blood work. Everything else follows from there.